I think there's something about teamwork with yours, and maybe what you
Yes.
learned during your esteemed fellowship.
Okay. Well, thank you again, everybody. Bausch and the Ivista team. This has been a fun couple of years getting to do this. Definitely one of the highlights of my fellowship. So thank you again. Let me see if I can share my video screen. Hold on.
Cool. I think we're streaming live on YouTube. Woohoo!
Moving on up in the world.
That's cool. I had my children explain Snapchat to me today. That was a fun experience.
Isn't Snapchat old?
Yes, I know, but I'm catching up.
Okay.
Okay. Are you guys able to see my screen?
Yes.
Looks good.
Awesome. So I first wanted to kind of just show a glimpse of what I've been doing for the last 6 weeks. So apologize if my brain takes a few minutes to kind of turn back on, but eventful last 6 weeks. I had a daughter, and this is kind of what I've been doing. Austin came and got to meet her, so she can she can tell you about her too. But this is kind of what I've been doing, and so now I'll turn my retina brain back on. But this has kind of been at the forefront for me.
It's the same brain, just it's
It's just
just using different parts.
multiple
It's
brains.
critical thinking. I do like how your daughter's constantly sticking her tongue out at pictures.
Yes,
That was a
well, that's the theme. That's how she rolls. So Jacob and I, spoiler alert, we actually are presenting the two different eyes of the same patient tonight. So I'm going to show kind of the first eye this gentleman had. This is one of our county hospital patients. This He's a 30-year-old man. He has type 2 diabetes, severe diabetic retinopathy. He's had, kind of unfortunately been lost to follow up. He had PRP and Avastin before, but he's representing now with bilateral TRDs, count fingers, hand motion. And the decision was made after a long conversation, making sure he's medically stable to proceed with Avastin, and then TRD repair to his left eye and then to the right eye.
How did you decide which eye to work on first, man?
Well, the left eye was kind of the worst eye in his case, and it's when I think practice patterns that I've seen that I have found that I agree with, is that the worst eye in a patient like this is sometimes a better one to start with to kind of at least get you the opportunity to get some trust, get some rapport with the patient, and in his case, it needed more work and kind of needed more urgently, because of the kind of the you'll see in a few minutes, but he had almost a regmatogenous component to his left eye, so that's how we decided. And he did get, the plan was definitely to operate also on his right eye, which is why we went ahead and did Avastin. I know it's also, it's always talked about whether or not to inject these patients when they have a tractional detachment if you're not sure you're going to operate. So that was kind of the plan, I think, from the
Were both
beginning for
surgeries
him.
scheduled already, or was it do the left eye and then see how it does and then schedule the right eye?
I don't think the right eye was scheduled, but Dr. Shrivastava can correct me if I'm wrong. I
Yeah, I
think
think his
we,
right eye had more of a vitreous hemorrhage too, so we thought maybe he'll get some clarity with anti-VEGF. And but the plan was get the left one done seeing, and then jump into the right one, and you'll see how both the left one and right one look. Neither of them look great, but the left one certainly looks worse. But
So
they don't. They
I
both
like
don't
doing
aren't
the better
winners.
eye. I like doing the better eye first because I feel like, especially a patient who like disappears on me, if I get the eye that I can save and I, give them vision, that actually makes them want to come back. Whereas if I give them an eye with oil, it doesn't see well, and they have pain or something, then they never come back and they never let me touch the eye that actually has better visual potential.
Yeah, we chatted about it together, this patient and I, and he wanted his left eye done because he felt like he could see enough in his right eye to work. He was actually working. He works just like kind of in a restaurant in the back. And so he thought he could keep working if he had just even the vision in his right eye. So he decided just the left eye. But I agree with you. I think that's a great option.
all righty. Well, let me see if I can get the video going. So he is phakic, again, young gentleman, 30s. So when we first entered the eye, I definitely am trying to separate the anterior posterior traction, but also notice these large membranes, subretinal membranes, and the preretinal kind of fibrosis worse along the superior temporal arcade. So again, just more concerning for a retinoschisis component as well as a tractional component that he clearly has. So separating what we can, and again, continuing to go around, revisiting some areas multiple times. I will say these cases, sometimes I find it's easier to kind of focus on one area, and then when you get maybe frustrated or you're not making the progress that you want to be, kind of leave that area alone for a while and come back. Especially like here, trimming towards the nerve, and then the macula is kind of just like swimming towards my cutter at the same time. That was a special moment, so I took some time away. So it was nice to just kind of come, step away. Go ahead.
And one of the things that I really like about how you're doing here, that's sometimes nice to do with the cutter, is you're obviously trying to get the gel, but then you're also kind of using the cutter against the membranes, it looks like, to be able to see how much traction is there. Is that something you've done before? Do you find that helpful?
Do you mean to just kind of like see if that's actually the problem area or not, kind of thing?
Yeah.
Yeah,
just
I
see
do.
like if you lift more, what it would look like.
And what the video doesn't really do justice for is I guess how much time there's spent just exploring without doing any cutting at all. And these kinds, especially for diabetic cases, I feel like it just never does it justice to, like, in real life, kind of how much assessment and planning and conversation and debating kind of goes back and forth in these cases. So the using it to kind of see if it would flatten again, is a good tool. And just there's a lot of planning.
Hey, Leanne, before you play from what made you decide peripheral opening first as opposed to maybe keeping that AP traction and going down to that posterior stuff? Why did you decide peripheral stuff?
There seemed to be an opening, and if there is an opening and it continues all the way around, great. And then I think that there seemed to be enough of a handle kind of from the fibrosis already at the nerve that it wasn't going to be necessarily an issue going forward. So it's just kind of take what comes. I think, but there are situations where both both methods can work, but in his case, it was kind of presented itself almost.
Yeah, I agree with you. I think I like this technique. If I can open the periphery, it just seems to open everything else for me. So I agree with you. I think you and I were chatting as we were doing this case of where to go first, and the inferior aspect seemed to open really quickly for us. So it made it maybe a little easier.
And I did reach a point where I felt like progress was not being made, and again, had trimmed at this area and really was concerned about the mobility of the retina. So decided to take our forceps and go after the stuff, fibrosis around the nerve, kind of pulling gently, seeing what came, and then luckily it kind of did separate nicely, and then sweeping that fibrosis out from the nerve, kind of along the arcade, gently exploring there too, and segmenting once we had that freed made us feel a lot better about kind of where to go from here. Kind of gave us a lot more areas to work on.
Hey, can you talk me through your cutter settings? What are you doing? What kind of cutter settings you're using?
Yeah, so you like to call this the vertical scissor mode. It's high, low cut rate, low vacuum, so 1,000, and then the vacuum kind of like 150 to 200, I believe, to 250 on the vacuum low. So, vertical scissors themselves could work for this kind of situation, but it would just take a whole lot longer, and then you'd still have all this fibrosis left over. But it seems to be more efficient to kind of use those settings to eat what we're cutting at the same time without having to worry as much about the mobility of the retina.
Yeah, I call this the weed killer, the weed chopper, like the hedge trimmer first, and then you can use the lawnmower, the high cut rate and the high vacuum if you want to. So you were definitely trimming the hedges first with some of these big,
your own lawn care, Sunil?
I do my in-laws lawn care because they can't do it, so I do theirs.
I think you did a really nice job in sort of separating these plaques here, but with those like nice large plaques like you have, did you think about using like a lighted pick at all? Or you're happy with how the cutter was progressing?
I think if we had gotten to a standstill, that's the situation where, some of the surgeons I've worked with, and I think that, I maybe even in my own practice would have started with a chandelier in a patient like this, just to kind of have the option. And, if things were not progressing, to kind of turn to it much more quickly. But in this patient's case, they once we got that fibrosis separated away from the nerve, it it seemed to be going fine. But yes, like a bimanual approach could definitely have been a good option for him.
Yeah, I think the nerve move there was key for this. I mean, I think that made the big difference for opening everything up. But even peripherally, you got things open really quickly. I think that helped too. We had it in the room. You just didn't open it.
Yes. Yeah. So again, kind of at this point, almost like stripping some of the peripheral vitreous away too was helpful. Kind of shaved all the way around for him. Started to feel good about where we were. But still kind of little areas of adhesion we're working on. Didn't ever really find a clear break. We were suspicious there's probably something underneath that big plaque that we just couldn't find, but we never found like a clear area to drain from, or that was obviously causing the kind of the membranes under the retina.
Yeah, so I'm curious, maybe from my colleagues here, Leanne's going to show some subretinal membranes. So have you seen diabetics with subretinal membranes without finding a regmatogenous component?
I have on the really chronic ones.
Yeah, here you go. Here's your subretinal membrane.
So, we're just still debating on whether or not we even need to address it. It is large, but predominantly nasal, although it does kind of extend superiorly and inferiorly. And here what we're doing is, since we didn't find a hole elsewhere to drain from, there is all this fluid under PFO when it starts to flatten. So we decided to see, how much does this retina going to flatten on its own, even without addressing the membranes. And it does. We can see the, underlying PRP scars that he's had, but it just is so large, and the concern is over time it's just going to contract and kind of create problems all over again. That after going back and forth mentally and verbally multiple times, I decided to go after it. And then
yeah, it was you deciding. I was like, well, what should we do? And it was like, taking it. We're taking it. Well, I guess we're doing it.
We're doing it.
Leanne's like, it's
So
not flattening. Sunil can't see anymore. He's like presbyopic.
Yeah.
It's not flattening. We need to remove it.
So tell us your technique. What were you doing here?
So creating a retinotomy, knowing that as we kind of pull this, I think, in hindsight, one thing I might have done is even gone a little bit more peripheral with the retinotomy. We were trying to get close to where the membranes were, but they just, and you'll see, they just opened up a lot more, I think, than probably was necessary, looking at it now. But it worked out in this case. But, in the future, that's something I might do differently. But grabbing it with our forceps again, kind of pulling it, separating these little, the kind of segments that are attached in various places, trying not to exert too much force because it is kind of a spider, underneath the whole retina here, but looping it around the light pipe, using that as kind of a fulcrum to pull it out, and it came out as a giant piece, which is great.
It's hard because when you remove these, the breaks, your like retinotomy gets so big so quickly. And then especially in cases like this where the retina is not normal. The thing that's curious about, I think, this one is sometimes the subretinal bands are under a lot of traction. So if you pull it and then you let it go, you often kind of lose it. And it's not just hanging around like yours was. It's good that you were able to like regrasp it pretty easily. But sometimes having your light pipe ready to kind of spaghetti it out and act as like an active fulcrum is important.
Yeah, they're like bungee cords.
Yeah.
And at this point, just lasering down the areas of the retinotomies that we'd already made. We decided to put C3F8 in him, lasering around that area of the plaque, again, concerned that there might be a break that we missed. So big thank you to Dr. Shrivastava again for letting us operate on this patient this time. He was actually 2200 at month 1 and flat and looking really great, which we're happy to see. Still has some gas, we'll see.
Look at that retina. I mean, that looks amazing. Preoperatively, I mean, I can't. You couldn't have told me that this retina was going to look like this, and after that appearance in the subretinal space. So, when you were removing the subretinal membranes, I think Kat was talking about like spaghetting it. Would you, your forceps you used were very specific. Would you have used a different one, you think? Or, you had I think you had the adaptives, right? They're like Echo type tips.
I think there was probably a lot more grabbing than this video that I was able to actually show with the editing. So I think I would have used something with a broader platform more teeth kind of a serrated, kind of just to get a better handle on it. I think from the beginning would have been more efficient, but they worked. They worked really well. It just kind of took a few attempts at grabbing.
Yeah, I think it was well done. So I'm curious, a couple things. One is, long case, right?
Mhm.
But not terribly long. How was the lens looking? Like, should we, we always talk about whether or not we should have taken the lens or not. Do you think it would have made a difference in this case? I'll tell you, his lens is still clear post-operatively, believe it or not. He has not lost his lens yet.
And I'm actually surprised because we talked about it when I was operating is I did a lot of crossing in this case, like more than we're traditionally taught to do in a phakic young patient. And I think the conversation at the time was that, he is somebody that is, diabetic, having a vitrectomy, very likely going to get one anyways. Like the more important thing is to make sure that we get good removal of his vitreous, even at the cost of crossing more than we would like to cross. And at the time, at the very end of the case, it got a little hazy. I think we were able to complete what we needed to, but I think from terms of not having as much postoperative inflammation, I like preserving the lens and I like the decision to do that for him. But I've definitely been in cases where that backfired. But
Yeah.
thankfully, it did not.
Yeah, I think you go either way. I'm curious, colleagues, what would you, I mean, is he young? He was like, I think he's like 28, right? 28, 29, 30
30,
year old,
yeah.
right? Yeah, I mean, a
Mhm.
relatively clear lens, but like that kind of traction rhegmatogenous. I mean, Kat and Caroline, Isan, what do you guys do? Do you typically take the lens?
Only if it's interfering with my view.
Yeah.
So I do a good slit lamp exam beforehand. If they don't have a PSE or kind of cortical vacuolar smoking that's getting in my way, I try to leave it like you guys did.
Mm.
But I'm also, your goal is to get rid of all of that traction, and there's so much vitreous schisis in these patients. So I remind my fellows, like, we don't just like willy-nilly reach across, but if you have a good plane and you need to get that vitreous up, like, who cares about the lens? We'll take care of it later.
Yeah, I'd echo that. I'm even surprised sometimes these really young patients, even if they get feathering initially afterwards, it takes a long time for the cataract to actually develop. Sometimes you've seen these people 5, 6, 7 years and nothing's happened. So it doesn't necessarily mean it will develop either.
I agree that
I,
age makes more of a difference than you think. Like often our older
mm,
peel patients are the ones who get their cataracts like, 2, 3 months later. But some of these young people will surprise you. And then I've gotten burned a couple times by doing these combos on patients, and they just end up with such inflammation afterwards that
mm.
their like iris will just scar down and they'll end up with these crazy like sneaky eye. It's sometimes nice to just keep it separate.
Yeah,
Yeah.
I think all those things are true. I think depression helps, just depressing that eye really well. I always tell the fellows, you'll miss me. The only thing you'll miss about me is I'm a really good depressor or I'm depressing. But and I think, I always make sure for these young diabetics who are poorly controlled, I do still put dextrose in the bottle to try to make sure, that just osmolar change that can occur. And sometimes in these longer cases, the lens can get cloudy on you. So, especially poorly controlled diabetics, I'll still put dextrose in.
I'll tell you that getting dextrose in a system that's not used to having dextrose is a challenge. So for graduating fellows, like if you're used to having that and you know the outcomes, sometimes your new surgical center will be like, "What's dextrose?" and it becomes a whole big deal. But if you're used to it, then fight for it because your outcomes are your
Remind them it's everywhere. It's dextrose is
outcomes.
everywhere. You
Is it
should be able
sugar
to get
water?
it's sugar water.
It's sugar water.
It's sugar water. It's a good thing. Leanne, any final thoughts? What an awesome job! So when you tag team to Jacob for the other eye, what words of wisdom did you pass off to him?
Oh, and well, not to Jacob. I seek help from Jacob all the time, but to everybody else, I think just something I've learned with operating is, stop and reassess frequently. And, maybe that's true for your career life and personal life is just take inventory, stop and take inventory, see where you're at, see what, you may not see because you're focusing so hard on one particular area that you're missing something somewhere else, especially in these diabetics. So that paid off for this case, but it's true for others too. And, and again, this is just OCT, but big thanks to Dr. Shrivastava. If this is how we feel, he's consistently able to, in these like really tough cases, make us feel just like a happy little baby, learning how to operate on these. on these diabetics, even though he's sitting at the side scope looking at us like this the whole time.
That is my look. I love the
Yeah,
eyes. That's it.
that is, I feel it, even though I'm not like seeing you, it's there. So again, big thank you to all the, people that have helped me along the way and have taught me this trade. And again, everybody with Cobra, the iVista team and Bausch to kind of letting us present. But super lucky. Thank you.
Nice job, Leanne. We're really proud of you. Excited to see what you do next, and really great job. In all seriousness about, learning from one eye to going to the other eye for these diabetics, I think sometimes it's really helpful, as you assess, like, what went right, what went wrong. And we actually watched your video in our own surgical rounds, like I think a couple weeks before we did the other eye. And I think it was really helpful for us, like as we planned for the second eye. And that said, with no further ado, Jacob Cox. Jacob is also our graduating second year from Cobra Eye Institute. Came to us from a Mass Eye and Ear. Is heading off to Tennessee. We're super excited for what comes next. Jacob, take it away, my friend. And you're on mute, or you're not talking.
Yeah, no. Well, first of all, awesome case, Leanne. Hard, tough presentation to follow up. We figured this was our last Cobra. So yes, we can teach you about retina and surgery, but why not also teach you about friendship and teamwork? And so, as you know, Leanne does one eye on this patient, and then a couple months later, I do the other. And then before I get going, again, being the last Cobra, just want to talk about or mention how much I've always appreciated getting to participate in these. It's been one of the great highlights of my fellowship, and a big thank you to Bausch & Lomb and iVista for putting this together.
You can thank Dr. Mruthyunjaya a little bit.
And Dr. Mruthyunjaya, of course.
Wow, like your fellows kiss up till the last day. Like, it's amazing. They're so well trained. It's amazing.
We do what we can.
As we kind of discussed before, it's a 31-year-old man who has TRDs in both eyes, secondary to type 1 diabetes.
I do like he has PRD. I don't know what PRD is, but that's exciting.
Typo. So initially,
that hasn't changed in 2 years, by the way. 2 years of your fellowship. The typo's still there.
I have a month to figure it out. So he initially presented to us. Well, this is first of all at our community or our county hospital. He initially presented at age 23 just for a routine exam, had mild NPDR, and then has had some inconsistent follow-up since then. Came at age 29 and did have some PDR in the left eye, so got PRP at that time. But again, then was unseen for 2 years and presented due to sudden vision loss in both eyes. Found to have TRDs as we discussed, and then had surgery with Leanne and Dr. Srivastava. And then in the lead up to our case, he actually had 3 Avastins spaced monthly. So we had a few more Avastins in the eye that I'm about to present. As you can see, this was his better seeing eye. He was 20/80. By the time we were getting around to the surgery, he was 20/80 in this eye, and as Leanne alluded to, 2200 in the postoperative eye. And then here's what we're up against. So you can see that there's obviously some pre-retinal hemorrhage, also a tractional retinal detachment that's threatening the fovea, fairly tightly adherent plaque here superiorly. And then the extent of the detachment is here, sort of the superior and nasal periphery, and then into the macula near the fovea.
Jacob, I think it's really helpful to see that photo. I'm curious because I think that there's different takes on whether or not you should wait on these TRDs until the fovea pops off or try and do it beforehand. What's your take on that now that you've seen different people do different things and you're about to go off on your own?
Yeah, I think there's a lot of variables that come into that. I mean, in this patient's scenario, this was his better seeing eye. He was clearly poorly controlled and seemed to be progressing. Yes, he'd done a good job with follow-up after his surgery, but he had this history of repeated, loss of follow-up. And again, with him being 20/80 in this eye, we wanted to get to it before the fovea became involved.
Yeah, and Jacob, I think, I don't know if you're alluding to it, but I think some of the stuff that we're seeing also, he had a subretinal membrane on this side as well.
That's right. Yeah, exactly. And so with the subretinal membrane, that also raises the question of, oh, sorry, there's an ambulance. Could there be perhaps a rhegmatogenous component that we're missing as well? Just a lot of factors that made us say, hey, let's not wait and mess around. Let's just take care of this eye, and make sure it doesn't get worse.
And for those first-year fellows out there that are going to be second-year fellows, this is a good one to start doing your own ultrasounds on. Sometimes you'll get an ultrasound done by your if you have a ultrasonographer. But these are nice to start to be able to kind of figure out planes. Where's your hyaloid? Is there a tear? Where's your entry point? Is it superbolus in one location? The ultrasound can really be helpful, especially if you're seeing them right on the table or right before surgery. Having that information can really be helpful. So the static picture may not give you that whole story.
Prithvi, do you find it helps for hyaloid elevation and such? I mean, I know you're really good at your own, but
I'm really good. No. I think it can be helpful. And especially if it's you're not certain that it's like a tabletop where, you're pretty certain it's going to be detached in the periphery. I think early on, if you have a sense that there is a separation at the hyaloid superiorly, especially if you've had a couple of tough cases and you didn't feel like you're able to see it, that could at least be the first place you're going to go, right? You might be able to start your dissection anterior posterior where that there's probably a good chance that there's that separation. But I think it's just getting into the habit of using the ultrasound on those cases where yes, dense vitreous hemorrhage, you can't see what's going on. Is there a detachment? But being able to separate those two, even in this case where you can look in, I think it's helpful.
Yeah. I mean, I know you have the extra long cord. Don't you wrap it around yourself like a Cobra around you beforehand?
Just like a Cobra.
Yeah, I figured it was much. Go ahead, Jacob.
So here we are just starting off. We were able to relieve AP traction pretty easily and temporally and inferiorly where the hyaloid had lifted in the periphery. And then just trimming down a little bit of this to, improve our view later on. But once we started continuing to do AP traction here, once we got up to this superior portion here, the hyaloid was very tightly adherent. And so trying to get release that AP traction was much tougher. This was kind of a good tip that I learned on this case that I've used since then on some of these harder cases, is having somebody do some depression in that area can actually sort of pop up that little small window of space to get the AP traction in some of these more adherent areas.
And I think one of the things you were doing while we were doing that is you came off your vacuum. Because sometimes you just want to press down on the pedal. You had really great pedal control at the high cut rate that allowed you to kind of just open that area up. So you were using more kind of the high cut rate and then the high vacuum settings, but you were really modulating really well, which is really important. It's really easy for the stuff to pop into your cutter very quickly.
And speaking of depression, I know that Dr. Srivastava is great at depression, but I should give a shout out to Caroline O, because she assisted me for a lot of this case. So it was kind of cool being towards the end of fellowship and getting to do a lot of this case, just me and the resident, with Dr. Srivastava in the back mostly heckling us and picking on us.
Never heckle.
So at this point, we've relieved our AP traction, but there's this very tightly adherent membrane here. And I actually deliberately left in a lot of the sort of picking around that I feel just comes with these cases. A lot of it is seeing what comes. So here, where it was so tightly adherent, I'm actually deliberately kind of manually lifting at times. I'll go back just here to show that, but trying to give myself some space right there. Those sort of moves, giving myself more space as I go along.
That's definitely a second year move. I think it's very hard as a first year to do that. It's not easy to have the confidence to do that. So that's a great sign.
Jacob,
you kind of understand the points.
Jacob, are you aspirating on that move, or were you just using it as a pick?
In that scenario, I have done that with aspiration, but in that case, it was just manually as a pick. I was kind of catching under the lip of my cutter and lifting that way, which is more or less what I'm doing here too.
I think this is a tricky spot right there. I mean, you'll have the better surgical view, but I think sometimes in those folds, you could be really safe because there's a deep valley underneath you, but sometimes this is one where you could get yourself into some trouble if you can't see the back end of the fold.
Yeah, we were trying to go kind of slow and steady with this and really visualize as much as we possibly could. And the other question I was sort of asking myself at times is, hey, this is the patient's better seeing eye. We haven't seen a break yet. And we're working in the superior nasal periphery. Like, I'm going to continue to proceed if I think I can do so safely. But if I have questions about it, maybe it's not worth risking a break. Commonly said, don't lose the case over the nasal retina. Just to back up a hair. So again, we did a lot of this kind of tight segmentation in this area until we could break through to basically free up and fully segment it. And then towards the end, we got a decent amount of hemorrhage as we, segmented the NV, and just trying to get on top of that quickly. So pop the pressure up quick, and then I end up aspirating the blood. You'll see here in a moment.
Carolyn, I had a question for you. When you have this bit of island that's there now and there's bleeding, he brought in the diathermy pretty quick to get that under control. Do you like using diathermy on the surface of those islands to shrink them? I know you had an opinion about it. I don't remember if it was like negative or positive towards doing that technique.
I don't like to diathermize the islands because I feel like it changes the architecture a little bit. And then it
doesn't make it easier? Doesn't it like bring it up so that you get your pegs ready to go?
I actually think it shrinks down, and then so they don't know what they're pulling. I operate at high pressures like indefinitely.
Like no worries.
Get this case done ASAP and then minimize the bleeding. I will diathermize the retina for like those bleeders that are oozing, because once they pool, they form these fibrin bands, and then you like thought you peeled everything really beautifully, and then while you're peeling something over here, now there's new fibrin elsewhere.
Okay, so for all these people like acting all smart and saying never lose nasally, like how much? It's always a question, right, Jacob? Like, have you figured out how much nasal can you leave in terms of proliferation? Like, what have they taught you? Because everyone's like, oh, don't lose it nasally. But like, what does that mean to you?
That's a great question. I don't think I still have a firm grasp on that. I hear it frequently, but at the same time, I feel like in my experience, we're always able to pursue the nasal retina. We've never kind of just stopped and left it. So I'm sure those cases are out there. I just haven't, I don't have enough cases under my belt yet to have seen those.
Kat, what do you tell your fellows? Like, when is enough, leave enough nasal, it's okay?
It's a balance for sure. I mean, I don't go after sort of plaques nasally, but I do like to get the AP traction relieved nasally. And I feel like that's sometimes missed because then that can contract. I also put in the chat, but I think it's funny that we're all talking about trying to avoid doing too much stuff in the nasal retina. And then I think that Jacob's going to show us he's purposely putting in a break in the nasal retina for us.
Well, if you look at what we were doing, if you go back, Jacob, to where you were addressing the nasal retina, the reason why we're in there, if you go back right here, like I mean, even though we had opened up AP, I wasn't convinced it was open. And so I'm looking at this configuration, and if I'm going to take that subretinal membrane out, I really want to make sure the stuff nasally is off. So you'll see the move here he makes. He gets out to the periphery really well. This move right here, this was where I started getting really happy, is you'll see he crosses this bridge right here, or this segment, and then it opens up a little bit more. And then we have this stuff posteriorly. I'm like, well, if you can cut across this, I know for sure this thing will relax now. And I think you really have one. And then I said, well, we don't have to get the rest of this off now. Once you've segmented this, leave it. And I'm okay leaving this a little bit out. And so to Caroline's point, yeah, it actually, the purpose of the diathermy was just to control the bleeding, but I wasn't going after that stuff anymore. We're just done.
Yeah,
with
if you're leaving it, sure, diathermize it. But if you want to peel that off, I feel like it makes it harder.
I agree. I do 100% agree with you.
It changes the architecture. And I also agree, like you can leave nasal stuff, but you have to release it so there's no traction or continuation elsewhere. And also lots of times at the beginning of the case, you do like the AP separation, you think you got it, you're in the right plane, and you start peeling these posterior things, and suddenly, like my fellows say this all the time, there's like this whole sheet, the whole vitreous skirt lifts up. And this is like aha moment that you never would have seen unless you actually try to get some of these plaques off.
Yeah, you'll see why. You'll see Jacob do a move here to make sure we don't do
that. Well, so moving on to the next section of the case. Unfortunately, the video software kind of cut out, and so it does miss a few parts. And one of those parts is I got a little, let's say, I got in a bit of a hurry trying to do some of the segmentation here superiorly, and did end up making a break. It was a very tight area, but I think if I had been just a little more patient, I could have avoided it. So at that point,
it was our cutter setting. If you think about what you were doing, if you look at like your next move, our cutter setting was still set on that high vacuum, high cut rate, and you were really kind of dissecting. So you pressed down and then it just popped in. So that's where I think, for us, it's just a really good thing. Think about what you're doing and maybe adjust your cut rate. And it's very easy to just on the machine, just go, on the Alcon, maybe it's your dense setting, maybe on your, Bausch, I have it as my shave setting or my, I call it something else, but like, we just switch back and forth between those two.
Yeah. And it was one of those scenarios where I was focused on the lip of the membrane or the plaque that I was getting underneath. And with that higher aspiration, it sucked kind of a distal leaflet and brought the whole thing in. So,
yeah, it's okay.
We're committed. Yeah. Now we're committed. We have to get any traction off that brake. And so just kind of slow and steady like before, trying to get underneath wherever we can. And here, obviously, we're on that lower vacuum, lower cut rate mode, the sort of pseudo vertical scissors. And honestly, at this point, I think it was probably enough, but so at that point, it was enough. Here, as we've alluded to, sometimes you can be fooled in these cases thinking you've gotten the hyaloid up and maybe there's still some there. So we're just confirming that, in fact, the hyaloid's off. Doing our, typical depressed shave in the periphery. And then this was something I debated a little bit as well, because I know sometimes we'll, quote, pull the plug out of the drain. And other times you kind of just leave it and trim it down. I think in this scenario, I was a little unclear if maybe there was still a little bit of traction emanating from the nerve over to this nasal fold. And I didn't see a really robust blood supply in it. I didn't think it was going to bleed a lot if I pulled it. So I figured I'd go ahead and pull the plug on it.
Oh yeah,
there it is. Nice job.
I have to wave it around, show it off. So here we knew from the get-go that we were probably going to go for that subretinal band. It extends, just like in the last case, we don't want it to contract over time, and it seems to extend past the nerve into the macula as well. So here, just trying to minimize how much I'm actually expanding the retinotomy as I pull the band. And initially, I thought for a second about doing that fulcrum move with the light pipe, but letting go here, it seemed like there was a good angle to just kind of pull it out, like sort of straight through the break without expanding it.
And you switched forceps there when the light turned on. It looked like you had end grasping, and then you switched to like max strips or serrated forceps.
Serrated.
I believe we were with the serrated out. I could be I think it was the serrated.
You did the serrated.
Initially, you had the end grasping, and then you switched to the serrated.
Yeah, that's right. Mm-hmm. And so from here, it's more or less just the standard steps, going to air for our posterior breaks. In this eye, it wasn't actually that long of a case, but we really did lose our view once we went to air. So it was kind of obviously making sure that we're able to get satisfactory PRP and laser around our breaks. But it was this was one of the longer steps just because the view was kind of tough at times.
I think you're out of focus. That's what it is.
That might also be part of it. And in this
look, you're out of focus. Look at the end.
I'm obviously accommodating. In this case, we went with SF6. We felt like the brakes were posterior enough. We got enough traction off to do that. So this was a more recent case. I'd say it was about 3 weeks ago now. At his post-op week 1 visit, he was 2200, which is down from his baseline, but he's got a little bit of shakeout heme. He's still got a bit of feathering. He's still got a bit of gas. And so all in all, he's doing well. Retina was clearly attached, and he's got good laser.
Nicely done. Good
Nicely
job,
done.
man.
I just got a comment for all the trainees about to become attendings. You see these kind of cases, and it's easy to focus on the retina issue, like, oh, he's got detachments, we got to take care of this. Don't forget, like, you're the attending, you make the decision for surgery, that buck starts and stops with you. This guy is likely very, very sick. Make sure you're aware, put in appropriate consults when necessary. You oftentimes get pushback from ASCs that they won't take these cases. It needs to be done at a hospital. Just be aware that, I mean, early on in my career as an attending, you come out and you just want to take care of the retina thing. And I've been bitten by this a handful of times with these really sick diabetics, and you don't think they're that sick, but something bad happens during the post-op period.
Yeah, our fellows know, my seniors know that this is something like this gentleman specifically. Part of the process now for me is before I'll do it, they have to go to primary care, they have to go to cardiology, they have to get cleared, especially these really, really sick ones. And then we start, and they have to show, so that way they show me they are coming back and such. And to Caroline's point, if you're going to live at a high pressure during a case and want their blood pressure so well controlled, so for a number of these TRDs, I'm like, we have time. I don't want you dying on the table. I don't want you dying in the short post-operative period. And my codes in the operating room have almost always been diabetic, sick diabetics like this. So it makes sense. I agree with you 100%.
Hung Ween asked a good question about in-office air fluid exchange. If you have, I guess, leftover hemorrhage that's lasting for a little while. Any thoughts, Carolyn? How often do you do that?
I did it a lot when I was a fellow because we had limited access to the OR. It was like once a week and, long wait lists. As attending, not so much, I just bring it back. It's quick. But you can, it's perfect. Either just make sure that you do a good ultrasound, the retina is attached, and then, I think it's easy to do. I did it as a fellow.
I think absolutely right. I think that we would do that a lot more. A 20 gauge surgery, I think, that would be something that was a reasonable option instead of taking them back in for that. A couple issues, I think, is if you had gas and you needed tamponade for a longer period of time, and how much of the gas do you want to sacrifice? Because at that point, I think you're going to lose any leftover tamponade that you'll get with that procedure. Sometimes it's just technically it adds a little bit of complexity to your busy clinic, and you spend more time trying to describe how to do it than actually like doing it. But it has been done. It can be done. But it just probably takes a little bit of a setup. Just like, how quick can you get your pneumatic up and going? Like how quick can you get your office exchange going? But I think most people would take them back.
I agree.
Along the lines of the gas thing, Prithvi, like, again, just tips I'm remembering when I was a young attending. These are the patients that can get huge IOP spikes if they get rebleeding under gas. The gas isn't necessarily preventing a bleed, especially if they had a lot of oozing during the case. They break through and bleed. Like these people go like IOP 50, 60, they're complaining of pain. And again, these diabetics, they already have some degree of neuropathy. They may not even be really complaining that much. So they call your office and you're like, wait till next visit, wait a couple weeks, wait a couple months. Just keep that in the back of your mind. You may want to bring them back soon.
All righty, let's see what you guys got on the Stanford side from your second year.
That was outstanding by the Cole fellows. We're up next. Karen, you're on. Yeah.
I think so. Yeah.
Okay. Yeah. So our first graduating senior is Karen Wei. You've all enjoyed her presentations for the past 2 years. She joined us from Mass Pioneer, where she and Jacob were just obviously awesome residents, and we got to work with both of them now as awesome fellows. Karen's going to be joining us here at Stanford when she finishes. She'll be on faculty with us, and today she's talking about surprise. What's your topic today, Karen?
So I also have a TRD too, but
There you go.
it's a little different
Karen,
than
I'm sorry.
diabetic TRD.
I'm sorry that you're staying at Stanford and have to work at Berkeley. I know what it's like. It's hard. Good luck.
I'm looking forward to being a super fellow. So I just want to say thank you so much for everyone's mentorship here. These rounds have been such a highlight of the last few years. They've been a lot of fun, and I learned so much each time. This is my final Cobra surgical rounds, and then my mentor for this was Dr. Smith. So we had a 27-year-old male. He came in for progressively worsening vision loss in both eyes for a period of a month. He does have a history of substance abuse, had previously used marijuana and cocaine, and then he has no history of trauma, no previous known medical history, and uveitis review of systems was completely negative. Here are his Optos photos. Yeah, so this was like one of the last patients to come into Dr. Smith's clinic that night. It came in at like 4:30. This is what he showed up with. No known medical history. Hasn't really gotten any labs checked recently either, but doesn't have any particular symptoms besides just slow vision loss over the last month. And he does have a little bit of inflammation in both eyes in the anterior vitreous chambers. I wanted to pause here. We can see that there's some vit heme, there's NVD, NVE, TRDs in both eyes. What would be people's approach here? Or what would you do at this point?
I can't see for sure. Are they sclerotic vessels that we're looking at here, or or are there sheathed at all? What do you think?
It was actually very hard to tell because
Okay.
there was vit heme and active inflammation, but we didn't necessarily see sclerotic vessels, but we definitely saw lots of NVE, NVD, and lots of fibrotic bands.
Fluoresceins can be helpful, but your view is compromised, so I'm not sure it's going to help you that much. And he's not a diabetic, is that correct?
He has no known medical history.
Okay, so maybe he's a diabetic. I like it. So, I think for me, these, it's still, diabetes, sickle cell, are hypertensive disease, like things that can cause ischemia. Those are probably my big three. And then inflammatory, I do the basic workup to start with, where the things I worry about, things like sarcoidosis, chronic tuberculosis, and syphilis are all on my list. And then you can have things like lupus and APLS as part of your differential. That's harder to figure out. But your most acute immediate thing is when you have active NV, there's little downside to putting anti-VEGF in the eye. So you can do your workup, anti-VEGF, and then, kind of over time as your view improves, try to figure this part out.
So
this is a good point that I don't think we need to rush to surgery tonight. 4:30,
So we ended up ordering a very extensive hyperviscosity workup, vascular workup, and uveitic workup. Given that he was African American, our first thought was either diabetes or sickle cell, but those both came back within normal limits or negative. And then he had some slightly mildly abnormal labs, but nothing that really gave us a slam dunk diagnosis. We ended up starting him on, after the infectious labs were negative, we started him on oral pred and some topical prednisolone and just gave ourselves a little more time to think. So he's coming back to our clinic, a week later after his labs are all back. And I wanted to ask the team, what would you do here in terms of surgical planning, which eye to do first? And I know Sunil mentioned this already. Would you inject anti-VEGF at this point?
What's the ultrasound like?
It showed fibrotic membranes and a TRD.
I'm surprised that wasn't shown immediately, seeing it's so infatuated with ultrasound and every single.
I know, right? So, that's the only intervention I can offer, right? Ultrasound, therapeutic ultrasound.
So he's telling us that, at least from exam, we thought his right eye looked less severe than his left eye. So I know we were talking a little earlier about which eye to do first, the better seeing eye or the worse seeing eye. Given both eyes are, I forget, hand motion or can't count fingers, we decided to proceed with surgery in the better seeing eye first. And we gave
Carolyn, would you inject both eyes today, or the eye that you're going to operate on tomorrow or next week, and then just wait on the other eye?
I'm gonna inject both today, and then plan the surgery for whichever I'm going to do next week. I'm going to see it post-op day 1 and week 1. So if he crunches or pops off, then I just book him for the next OR day.
Asan, does that sound about right for you? Or are you going to wait?
Yeah, we're going to be seeing him pretty close anyway. If he pops off, you go to the OR. I'm not as worried about that happening. I'm going to want preoperative anti-VEGF on board anyway, so might as well start it.
Yeah, so we ended up actually just doing anti-VEGF first in the better seeing eye, the right eye. He actually underwent surgery in the right eye first with Dr. Sanislow and Dr. Smith. I was not involved in this case, and he had an incredible, amazing outcome in this right eye. And because he did so well in this right eye, we thought Dr. Smith and I would try and handle the second eye, which is the case I'm going to show.
Did they see something at the time of surgery that led to a better diagnosis?
I think with the anti-VEGF preoperatively, a lot of the blood cleared and some of the NV regressed. And at least from reading the op note, maybe Dr. Smith can comment, they were able to dissect off those plaques pretty well and get the retina to flatten very nicely.
Yeah. So
the one thing,
so I'll just jump in here. A couple of things. One, it was Karen's an amazing fellow. So the day this guy walked into my clinic was an afternoon clinic, and it was one of those clinics where I always, I see a lot of patients always, but it was one of those clinics where like the patients that were supposed to be straightforward and normal, like had problems. Like, so your intermediate dry AMD follow-up patients like have wet AMD is one of those. And Karen wasn't actually assigned to be in my clinic that day. She was in somebody else's clinic, but she came by at the end of the day, and this guy walked in, and our head photographer had come and found me that day. And usually when the head photographer comes and finds me, it means something's bad. She was like, you got to look at these pictures. And I think as I'm sitting here on my laptop, the pictures don't do justice to kind of what we saw that day in terms of how bad the eye looked, especially how bad the left eye looked. And so we did talk about an FA, but there was no view to actually see anything. And so in terms of our surgical planning, the reason we did the right eyes, I showed the pictures to Steve Sanislow, and his comment when he looked at the left eye was like, I don't think that eye's ever going to see well again. So let's fix the right eye and see if we can get him some vision. And then we can try the left, you could try the left eye, but let's try to save the right eye. So when he went in, there was still actually a lot of blood. It looked like a diabetic TRD, honestly, right? So there's plaques in different areas, and the hyaloid was, of course, down because he's a young kid. And so there, looking at this, we weren't like, oh, this is clearly XYZ from a diagnostic standpoint. It still didn't really, there wasn't, crazy vessel sheathing. There wasn't, signs of inflammatory plaques all over the place, right? So we still weren't entirely sure exactly what we were dealing with. But we were able to get the retina flat and, get some good laser in. And, they had a great outcome of this eye. I mean, the guy was, just about in tears when he came back and saw us when the bubble went away and he could see again. So.
Yeah. So we had an incredible outcome in this eye. So we're hoping for, a good outcome in the left eye, but, we talked to him preoperatively about a very guarded prognosis. As the left eye had much more severe disease. This is his left eye after some anti-VEGF. I think he had 2 of them at this point. And then he also had a course of oral steroids as well. And then during this case, just because we weren't sure of the diagnosis as well, we also took a vitreous sample to rule out malignancy and viral PCR too. So in terms of how we approach this case here, so kind of similar to the other cases, we did end up approaching this like essentially a diabetic TRD, but we can see some synechiae in the front of the eye. And going in, we can see kind of these fibrotic membranes all around. We're working on separating the anterior posterior traction here. And we can actually see that the superior retina does have attached areas, and then there's these kind of fibrotic plaques that are extending over the macula, but we're actually able to segment this part more easily than I would have thought, which we were really optimistic about. I really liked actually putting in some early laser at the beginning in the areas of attached retina, because I feel like it makes lifting up the hyaloid and the membranes easier later in the case. And kind of here we have this large nasal fibrotic membrane and infratemporally as well. And I think Leanne was talking about this. We're kind of jumping back in between these two areas and kind of working on them separately. We're using mainly the max grips, and actually rewatching this video, I was commenting to Dr. Smith that maybe we should have put in a chandelier, because I realize I'm not the most efficient with one instrument here, but we do have success at the end.
I like how you're approaching it. I mean, I think you're going. I mean, it's okay to do them one-handed. It's okay. That's fine. Nothing wrong. No one's grading your style points. If you get it surgically accomplished, you're good.
But it's very satisfying to get that plaque off the nerve right there. Kind of start trimming it down, but there's still, it still extends out further into the periphery. But really, I do notice as I'm watching this, I am crossing over quite a lot. He is phakic here. But I think, our main goal was to try and get this retina flattened. We luckily were able to have a relatively clear view for most of the case.
Were you trying to segment that, or was that just trying to use the cutter to peel that more peripheral temporal fibrosis?
I think I was trying to peel it, and kind of switching instruments a lot between the max grips and the cutter to kind of pull it up as much as I can.
It wasn't super fibrotic, like some of the TRDs that we see. It's I don't know, a little stiffer than this, and it was more malleable, and so there was a little bit of segmenting that we did here, but it was more kind of switching between the cutter and the forceps to try to slowly tease this off without creating breaks, right? So seeing if we could keep the retina in one piece, and I think that as Karen talked about here, putting in a chandelier, we actually talked about it during the case. It was coming up nicely. It wasn't maybe quite as fast as it would have been if we had a chandelier. We used the light to give us a little bit of counter traction at different times. And it was just more taking our time and not yanking it up. And I think that we're actually operating at the main hospital on a Saturday, so we had a little bit more time. And so I think taking that extra time is why we were able to get everything off without actually creating any breaks in the retina.
Yeah, we did find one small hole here, not clear if it was iatrogenic or maybe already there previously, but we just diathermized around that area. And then we decided to also stain with green and peel the ILM, which I actually really like in these like PVR detachments, because it helps you know that at least you're getting the hyaloid up off the posterior pole. Obviously it's always challenging peeling on detached retina, but I really like doing this, just because it makes me feel that we know we got off all the traction, at least off the posterior pole. But I don't know if this step is completely necessary, but I do feel like it helps now.
In the other eye, the hyaloid was really firmly adherent. And I think the other reason to do this was I felt like actually the second eye, I was a little more confident that the hyaloid was up, but at least we knew we had it off the posterior pole. And, given the fact that he's already got membranes, if you can get the ILM up and get a peel centrally, I certainly feel better about that, ERM down the line or whatever else. So I thought it made sense to do this, and, got a good outcome, certainly got the hyaloid up.
Kat, the decision point to peel ILM in a TRD like this, is this something that you're going in at the start of the case saying, yeah, before we leave, that ILM's coming off? Or is it kind of like, well, it looks pretty good and stable and things have gone okay, now I still have energy, I'm going to take the ILM? Like, how do you decide that next step.
I don't know if I would have planned here to necessarily take it off. Sometimes if I have obviously like an RD with a MAC hole, like I plan pre-op to do that. Or if somebody has like really aggressive PVR to try and get rid of the scaffold here. Here, I think you'd have to see how it goes. You know, the thing is that that vitreous traction on the nerve was just so much that sometimes, you know, it can kind of trick you that, you know, you think you got it, you didn't. So I might have to decide then. This might be one of those cases where I like put in Kenalog again, make sure I feel comfortable. I got the hyaloid. You know, if your view is good, go for it and you feel like it gives you extra peace of mind that you got the hyaloid. But I don't know for these cases if I would go in planning on doing that.
I think in this one, you know, the double Avastin and time, you know, kind of really delineated that posterior hyaloid, you know, pretty nicely. So I mean, that felt good. Though I'm pretty quick to get Kenalog in these eyes. Ethan, what about peeling ILM on diabetic traction? Is this 100% of your cases, or
No, sometimes we'll throw in the stain, take a look, depending how ischemic the retina is. You know, using preoperative OCT is always a good marker. If it's already like pretty thin and atrophic, I'm more worried about us creating iatrogenic breaks at that point. But if it looks like it stains well, comes off easily, then we take it.
Yeah, I think sometimes it's like, you know, you stain, you start it, you see how easy it's coming. If everything keeps detaching as you're pulling up, then you kind of let it go. Like you made a break, you've broken the plane of the ILM. Maybe that's something, but you know, you don't have, just because you put it down doesn't mean you have to get it all off. Especially, you know, your other surgical goals seem to have been pretty well met.
Yeah, I think if I recall correctly, we decided to kind of peel, we made that decision intraoperatively. Like you know, our view was still good. We felt like we had good access. The ILM was coming off decently smoothly. So we decided to take it.
Yeah, and the other rationale for doing it, I think in this case was, as Karen had mentioned, there was a thought that near that temporal area of traction that there might have been an iatrogenic break. I don't think it actually was a full thickness break, Karen, because when we went back, we actually lasered there and laser took. So I actually don't think there was a break, but there was some concern that maybe there could have been a break. And so we were like, if we've got a posterior break and maybe the hyaloid's down, like bad things could happen. So let's see if we can't peel and get it, you know, give us the best chance of this eye staying attached. Again, in hindsight, I don't think this was essential. I think we could have stopped and not done this, but based on how it stained and the fact that we were able to get a flap started and get it peeled, I felt better at the end of the case having done it.
But we can see the retina really loosening up here, especially once we get out of the flat lens. And then I was trying to peel with my left hand and I could not do it. So we stopped peeling here. So this is after the peel. You can see that definitely the retina looks much more relaxed. We decided to try and go to air here. But here,
Karen, can I stop you for a second?
Yes.
It's something that people never want to do, and it's great you just admitted that. If you're really uncomfortable peeling with your left hand, but you needed to get access to something out there in the temporal periphery, people don't ever think to do this. You can just swap your chairs, go temporal, move your infusion supranasal, and peel with your right hand and get what you need to get. We just never think that way because we always think we need to be operating retina superiorly. But again, it's great of you to like recognize that, like, oh, I'm not, you know, I may cause more damage with my left hand here. That's an opportunity for you. You can actually switch around your ports and do what you need to do.
It's a great idea. So under ear here, kind of seeing if we can drain from this break, but we didn't get too much fluid there. I think we were talking a lot here, whether or not that leaving that amount of fluid was okay or not. We ended up deciding to do a focal retinotomy as well. And trying to drain. Sorry, I don't know why my view got so bad here, but we're trying to drain to see if we can get some of that posterior fluid out. I think we get some, but there's still a good amount left in the macula there. And we lasered around there as well as the other hole. And laser took very well. I think at this point we felt that we achieved all of our goals of surgery, relieve the traction and get all the breaks covered. So at this point we decided to kind of leave that pocket of fluid and put in expansile gas here at 16%.
So Neil, would you have hit this patient with like perioperative steroids at all, or like,
Yeah, I mean, I don't think it's unreasonable, but I didn't see anything in that eye that screamed at me like this was inflammatory. But I don't think you would have been wrong if it once you had the A1C and you knew his blood pressure was okay. I don't think there's a downside to doing that. But I think I see sneaky eye on the iris. Maybe am I if I'm incorrect or not? But if I'm correct, but
Yep.
if I saw that, I would probably have said, yeah, you know what, go ahead and hammer them with some steroids, perioperatively.
So we did have him, we put him on oral steroids before surgery, but he had been off it for a couple of weeks beforehand, but we did an oral steroid prednisone taper for this guy. And he was
Yeah.
still on, and the reason we did that is because there were the synechiae and there were some cells in the front of the eye. So we're like, there's something inflammatory is going on here. And the eye was quiet at this point. But yeah, I still weren't really sure because like when we were in there, it just didn't look pathognomonic for anything, right? It's like it looked
No.
like a diabetic or a sickle cell like TRD still,
I mean, his ACE was a little elevated, if I'm correct.
Yeah,
Am I correct? And so there are, I mean, I would get a fluorescein now,
yeah,
because I do think there it's helpful to see if the sarcoid can present like this. This is not an unusual way. Sorry, it's
yeah,
not, sorry, it's an unusual, rare way, but it does
yeah,
occur where they walk in super ischemic in both eyes and with
yeah,
artery occlusion. So
yep,
it's not unreasonable to do.
yeah.
Great
Yeah,
job.
thanks. So
How do you
this
do?
is him at 1 month. Unfortunately, he's still hand motion, but he has a giant PSC.
Yeah.
So I'm
40
hoping
plus PSC. What? I've never described one that as a 40.
Oh, it's not 40 plus. It's meant to be 4 plus.
It's a mass eye and ear, typos. You guys have experienced it as well. Good job.
But he has a large PSC, so I'm hoping once he gets his cataract surgery that we'll have a good visual outcome for him. I mean, notably the macula does look pretty flat. I was worried about a fold or something with all that fluid left there, but he's doing it looks pretty decent. I mean, he does have some atrophy on the OCT, but I'm hopeful that he will ultimately do well.
Yeah, and on exam peripherally, he looks great. Essentially it's where you can't see because that's where the PSC is living. So,
But we're very excited about this result. But from a social standpoint, he actually lives pretty far away. It's pretty hard for him to get in. There's a lot of insurance issues. But we finally managed to get him a chest x-ray, which showed bilateral mediastinal adenopathy. With, now we're thinking, really, could this be sarcoidosis? And then he actually also had an MRI head for an unrelated recent episode of aphasia and weakness where he presented to an outside ER, and that actually showed multifocal leptomeningeal enhancing nodules, concerning for maybe a granulomatous disease. So I think we are thinking now that this is most likely ocular syphilis, also probably with neurosyphilis.
sarcoid.
Sarcoidosis.
Or sorry, sarcoid. Sorry,
Yeah.
sarcoidosis. And we're working on getting him follow-up for uveitis, rheum, and neurology, but it's been tough, but we're getting him into the care that he needs for his sarcoidosis, not his syphilis.
Absolutely. And you have one eye with good visual recovery, the second eye that's attached now, and you probably saved his life because you've uncovered.
So the
all
question that
trouble.
I have for Sunil and others on the uveitis side is, so this guy, one of the things that's been really challenging is the social situation. So a little bit more background. When he first came in, he also had a history of cocaine use relatively recently. So I actually initially thought this, after everything came back relatively negative, I thought this was Eales disease and cocaine was a trigger, and that there's been some case reports of that causing like occlusive disease in patients presenting with TRDs. Ends up, turns out that this is sarcoid. And he's having a lot of trouble getting in the Kaiser system to see anybody. His like next appointment with immunology is in like September or something. So, and this is after going to the ER with like aphasia and this MRI. Like no one's done anything for this guy. So I'm like, okay, we're going to start him on steroids. We're going to get him to see our uveitis doc. Sunil, what would how would you manage this guy as we're trying to get him in to see an expert? I mean, this guy looks like he could stroke out, right?
Yeah, you know, neurosarcoidosis is very severe and can progress very quickly. So these patients, if they're not on immune suppression, this is someone I put on anti-metabolite and anti-TNF. That's what I typically use for neurosarcoidosis. I would have them on, just keep them on moderate dose steroids at this point, oral. And the challenge is he's going to get side effect complications with it, but at least you're protecting him. So I would do the burst again and then taper him. I wouldn't taper him below 10 or 20 milligrams. I'd probably keep him on
Okay.
at least some moderate dose of steroids, and that will probably protect him some.
Awesome. Super helpful. Thanks.
Great case, Karen.
So
Nice job. Congrats.
We'll move on to our last but not least senior fellow, Austin Knapp. So Austin also finished her residency at the Cobra Institute, where she and Leanne were co-residents. Austin is going to be joining the retina specialists of Michigan in Grand Rapids with several Stanford and Cole former fellows. So it'll be a kind of a nice group up there that she's going to join and enhance.
Watch out for that Eddie
case.
guy, though. That Eddie guy is a troublemaker. That's the one I would worry about.
Austin looks frozen on screen.
She's just
You
sitting.
guys don't give your give him the ultra premier Wi-Fi. What's going on here, Prithvi?
Well, we felt
paying for it?
we felt bad because none of the computers
I
work at the Cobra
completely
Institute,
quit.
so we figured this is just to make you feel good on the last day.
You back, Austin?
It's not working.
Do you want to send just send it via drop? Oh, did you already send it to
Okay.
the crew on Dropbox?
I think it's on the Dropbox. I think I saw it earlier this evening.
Okay, we'll
Yeah.
try to open the Dropbox.
Yeah.
Do you guys want
Sorry,
to tell us about the next Cobra while we're waiting?
Jar, do you want to try to grab it, or do you want me? Prithvi, you want me to grab it? Let me grab it.
Yeah.
Off the Dropbox.
I can try
So
to.
Thanks.
our next Cobra is going to be right after the start of the academic year. It's going to be on Monday, August 26th. And then even more exciting, our Cobra Live is going to be at the AAO on Friday, which will be October 11th. Sorry, October 18th. That's the week before. So October 18th in Chicago. So looking forward to seeing you all in person.
Get the date correct, man. What are you doing to me? You're killing me.
We'll do it both weeks. It's all good. So if someone can pull up the
Sorry,
case.
I'm trying.
Yeah, that's okay.
Yeah, we're
My Dropbox is full and it's yelling at me.
I think I have it. 1 second.
Okay, I think
I got it. I got it.
Yeah.
I got it. It's just downloading right now. Give me a second.
Yeah, same. Oh, I think I have it open now. I can share my screen.
Go for it.
People can see it, right?
Not yet. I can share my screen too if you need it. I'm sharing my screen. See if you guys can see it. Can you see it?
Yes, we can see something.
You see the eye?
I see an eyeball. Okay, we'll
Go ahead. Take it away.
for a second.
Yeah, pause it.
Awesome.
Go for it, Ross.
Is Austin still here?
She's on her phone.
Well, we had to make it exciting for her last week.
All right.
I mean, this is how it goes. Hey,
This
so
was the
Prithvi,
case.
what are we going to
I
do at
think I
Cobra
have
Live?
her PowerPoint presentation too. Let me see if I can download that.
She's
Go
connected.
for it.
She takes a village.
I also have it. It's already in my email. Want me to pull it up?
Can
Yes,
anyone
please.
hear me?
We can
Yes,
Yeah,
hear
we can hear
you.
you.
Yeah,
Yeah.
perfect.
Hallelujah.
We're just pulling up your slides, Austin.
So
Yeah.
comical.
I have her
So
slides.
comical.
Did somebody else
Okay,
have
I
a
can
computer?
I can
Oh,
stop
you
sharing.
guys are the
Stop sharing the screen. Yep.
Yeah,
Got it.
I stopped sharing. So if someone wants
Okay.
to share her slides, and then I can
I'll
share her video.
I'll share. Let's see. Where are you? There you are. Steve.
Oh, thanks. Thanks, Dr. Pan.
No problemo. All right.
It's a cool
All right.
case. That's not a TRD. I don't know if we said that already.
Go for it.
Okay.
Okay. So this is a case that I did with Dr. Narala at the Valley. And this is a 63-year-old guy who came with redness and pain and decrease of his vision in his left eye for several weeks after, quote, doing something with drywall and getting dust in his eye. He has no like relevant past medical history or previous like ocular surgeries or anything like that. You can go to the next slide. So on exam, he was hand motion, and the pressure was 18, but he was noted to have a lot of injection and edema in the cornea and just a lot of intraocular inflammation with anterior chamber cell and flare, and no view to the back. He had like a 4+ NS cataract and like these pigment deposits that we noted like on the anterior lens capsule. We did do a B scan, and that didn't really, the retina was flat. There was no masses. There was no RD, and just a little bit of debris anteriorly, but otherwise it was pretty unremarkable. So you can go to the next slide. So we did, like basic uveitis work, started on topical steroids while we're waiting for some of this stuff to come back. And then, he came back like a week later or something, and all this resulted in, his exam was really unchanged, like nothing had improved. He wasn't saying he was, the pain was better and the exam hadn't changed. And then there was this piece of information that came out, if you want to click, that he, like a year ago, he said, like had maybe like decreased vision and like redness in this eye after he's like a carpenter or something, was working with a nail gun. So we sent him for imaging, and it turns out he has this foreign body in the eye. If you want to click again. So axial and sagittal. So from the CT, we can see that it looks very anterior. And this is probably why like we had multiple B scans on him, like serial B scans, and we never saw, and it's pretty small, so we never saw like any shadowing or anything. But I'm guessing it's because it was so anterior, like sitting at the pars plana, and that's why we couldn't capture anything on the B scan. So if you want to go one more slide, yeah. So like previously he noted, before all this happened, that his vision potential seemed pretty good, like around 20/50 or 20/40 in this eye. Yeah, everyone's saying like consider UBM, etc. And I agree now after the fact, but when he came initially for uveitis and cataract, like you're not automatically like, oh, get a UBM. Like it wasn't until we sort of had this other history that we honed in on this potential etiology. So for us, and I think if, this is a point of discussion, if people could maybe chime in on how they would approach like getting this chronic, small, probably metallic IOFB out, that would be great. But my thought was when I approached this was he had good vision potential. So, and, with the anteriorly placed IOFB, I was hoping to take this out from the front actually, like through the cornea. So that's why I plan to do a phaco and try to leave, like the anterior capsule intact, potentially for even like a sulcus lens in the future. Like I was pretty hopeful that we could get the vision better in this eye, and just make a posterior capsulotomy and kind of bring the IOFB through the corneal wound. So we wouldn't have to make more extraneous wounds. So that was my initial thinking on going into this surgery. Does anyone else have any thoughts, or like would they approach it differently?
I think that's a great idea. I might have done a UBM just to see if it was in the anterior segment versus posterior segment, and just to give you a better idea maybe where it is. But I would do the phaco, don't put the lens in, and then decide on the lens after you figure out where the IOP is. Or it's not a reason. He's pretty young. He has a cataract though. He does have a cataract. So then,
oh yeah, it's like 4+. There's no view.
Yeah. I like your plan. Or and doing a pars plana lensectomy is not unreasonable as well. I mean, because you might make a bigger wound too. So I think both of your plans make sense.
Yeah,
if the lens was clear, I wouldn't have planned to do a phaco, like just to get the IOFB out. But in this case, yes.
Yeah, exactly. So yeah, I think, as the senior send off, we had this plan, with the information that we had, and, as surgery goes, your plans change. And I feel like you need to be flexible and adaptable. So that's one takeaway from this case for me as I start thinking about going off into a world of my own. But this was our plan initially. So that's how we started. You can see the eye, it's pretty inflamed and not happy looking in the view. While I'm sure I accompanied Jacob in the accommodation department, this, at least in the beginning, was not due to my focusing, but the cornea was just, we knew the view was going to be an issue for the whole case. Just even doing the phaco. This was one of the harder phacos I've done ever. But yeah, so we're approaching anteriorly, obviously using Trypan. Of course, his iris is very mobile and floppy, so that adds to it too, which is lovely. And like I said, like this is the view. It's pretty not great, but we tried to stick with our initial plan. And you'll be able to see, like when we go to vitrectomy, we actually did leave him like a very good anterior capsule if plans allowed for a sulcus lens, which, spoiler alert, they do not in this situation. But yeah, so we take everything out. And then another thing, of course, is preparation. Like, what are we using to take this? Maybe you could pause for a second. Like, what are we going to use to take this out? Maybe some people could talk about like what tools they prefer for different situations. But we knew from the measurements, it was around like 2.5 millimeters, 2 to 3, probably metal, but not 100% sure. So of course, we're thinking like using IOFB forceps, but at the county, we don't have those. So then we were kind of, reaching for other things that we could potentially use to get this out. We did have in the room one of those urology stents, like the basket stents that have been reported in case it fell backwards. We thought that would be a better way to get it out from the like posterior pole. We also had a magnet that we did have at the county. So that was another thing that we were considering too. But I don't know if anyone else has any things that they like to go for.
I like to put a chandelier on these eyes, and then I do like to open the conjunctiva, at least temporarily, so that because sometimes I think you need to make a bigger wound. And then if you don't have it at the county, and we've had this issue before, but if we are planning ahead of time, I'll call the rep. Like Bausch makes a whole set of disposable IOFB forceps, magnets, BBs, and you can get them from them, and they'll usually send it to you. So that's what I like to have in the room.
Yeah, the only thing for prep is I probably would have opened a peritomy, just so it's available, right? So if it didn't work going through, or there was some issue with the passing it to the front, or if it keeps falling to the back, then at least it's ready to go.
Good points. Okay, you can keep playing. So yeah, basically, also what happened was as soon as we got the nucleus out, the phaco machine stopped working as well. So there's also this like adaptability. So as you can see, I'm using the cutter to like remove some of the cortical material as well and make the posterior capsulotomy that we were planning to do. And maybe it's just my screen, but yeah, the view A was very poor, and we knew that was going to be the case. But what you're seeing is what is real. Like the vasculature is very attenuated. And the retina just looks kind of like atrophic overall. And we felt like I don't know, the view is not as good as it should be. So that's when we decided, this eye probably doesn't have a good visual potential. And the most important thing is addressing the reason we're in surgery right now. So that's why we decided to take the capsule at this point. So I'm kind of spaghettiing it with my cutter anteriorly because I wanted to get a little of it because I thought it would be interesting to see if this was part of the reason why we couldn't see very well. And yeah, you can see the capsule is like completely orange. So we did send that for pathology, and then so we're able to now visualize and you see the views a lot better. So I think the capsule was like causing a lot of issues. But there's the IOFB sitting in the pars plana, for better or for worse for this gentleman. So we obviously used Kenalog a lot, made sure that we got a good, the hyaloid elevated, good peripheral shave, etc., especially over the area where the IOFB was. We were kind of surprised actually that it hadn't fallen or anything yet. We elected not to put PFO in at this point. I'm not sure if that's people's go-to just automatically in the situation in case it does fall. Would anyone have done that?
No.
Okay.
Yeah, I tend not to, but I mean, I don't think anyone's faulted, and I think as Asan said, they just get stuck in scar tissue. So I like putting this is where I like using the chandelier and then using like a forceps or a magnet, and then the cutter in my other hand to separate it.
And this
So
has been there for a year, so probably more
yeah,
fibrotic than like fresh.
if you want to pause, can you pause the video, Rams? So yeah, if you saw, like, the view is getting very difficult because the pupil is starting to come down. And we did debate putting iris hooks in, but I felt like I would actually appreciate the iris in this configuration if it's going to go as planned for me taking it from the front. So that's why I decided not to do that at this point. Obviously, if we were struggling or having issues, then we could always do that. And like Sunil was saying, sort of convert to a more posterior approach. But I want to at least give this a try because I felt like the angle was good and we kind of set ourselves up for success. So I thought it was possible. And you could see I tried to reach with my left hand first just because, that way I wouldn't have to do like a hand over hand situation and risk dropping it. But we were using just regular like max grip forceps and it barely was able, it had to be like in the perfect configuration to grab the IOFB. And so coming straight on was not the best angle. So that's why we switched hands. And then I sort of converted to a hand over hand technique. If you want to play
interior, Austin, that did you think about not using it through like the recite, the posterior view system, and just doing a deep anterior scleral depression like you do for anterior PVR? Like a la Buzz Krieger days, like I used to do as a fellow, and you can literally just like depress it into your pupil, grab it from the front.
That's a good thought.
That's a great tip.
I think it would have been really hard with this pupil. Like you would have had to have been like all the way across the eye. But yeah, I think that's a really good. That's a really good point.
And like the beauty of iris hooks is not like a Malugan, right? Like the iris hooks, you can put them in, and then whatever one you want to remove, you just pull it out, and then you have the iris as a trampoline to hold your body.
Yeah, I agree with that. That's the way I would go. I agree.
You can play. So I'm grabbing it with my, like at a different, on the side angle and bringing it forward. And it actually didn't have a lot of, like we shaved a lot, very closely around it. Another beauty, the magnet's not working, as you can see. So initially I was not trying to do a hand over hand technique. But the magnet, I guess, was not magnetized. And as you can see, like this IOFB, it was like an Ozurdex, like it was just kind of like disintegrating. So that's when I decided to go to like a no touch technique because I felt like that was going to be the safest. And so I just lined it up with Viscoat in front of the corneal wound and just applied, pressure from both directions to get it out without any more like manipulation and risk like small pieces getting around the front. And obviously, we cleaned out the front and, tried to get as many like little fragments as we saw. And when there was no bleeding, there was no wound, like we looked very closely and we didn't see any issues in the back of the eye. We did inject antibiotics. It's probably not necessary, but we were there. So we were like, we'll just do it. And that was it. Then we just hydrated the wounds and left them under fluid. with no capsule.
Superb.
And then I'm not sure. Yeah, I have one follow-up picture, but we did send the capsule and the foreign body for pathology, and like we did call them and tried to ask them to be like CSI people and see like if they could identify like what metal it was, because it's kind of weird. Like if it was iron, I would think that he would have had issues a lot earlier than what he did. So I'm not sure if it's some other like less toxic metal or coating of metal on this piece of.
No, this is iron. This is
iron.
This is the timing of iron. I mean, you said it when you saw the attenuation and saw how it broke up, and the density that capsule actually showed you it's siderosis. That's what you have.
Yeah,
I think he got his cataract, and then the retina started disintegrating, but he couldn't really tell because he had the cataract.
Yeah, so post-op week 1, that's what he looks like. Still hand motion, pressure is good. I mean, he still has inflammation, etc. We're trying to get that under control, but yeah, I'm not sure how much his vision is going to improve at this point. But mission accomplished.
Mission accomplished.
Rams and everyone at Stanford for the amazing 2 years I've had here. It's been awesome. I've obviously learned a lot.
Well done.
Nicely done.
What do you think, Sunil? Do we sign their certificates or what?
I have already had to sign their certificates in order to actually get it. So it's already done. No, actually, it's not done. You still have to come back for the next day.
So our next Cobra session is as mentioned, August 26th. We hope all the graduating fellows have great success in their new adventures and practices, and hope you'll still come back and offer your wise experience as your careers progress. We're excited to call you friends and colleagues. And if you're all, sorry.
No, go ahead. Sorry.
Yeah, and if you're all planning to be at the AAO during Sub Day, Friday, October 18th in Chicago, details to follow on location. So really proud of this entire crew here, Sunil. You get the last word.
I want to thank also I know there are fellows on session who are listening in, who are graduating as well. Congratulations to you, and we'll love meeting you and seeing you at our meetings, and we'll look forward to being colleagues. Thanks again to Bausch and iVista team. We'll see you guys in August. Have a great graduation.